Okay, good evening, ladies and gentlemen, and thank you for coming along to Wolper Hospital's first Wellbeing evening for the year. I'm Dr. Alan Schell, and I'm the chairman of the Community Partnership Committee, and our Wellbeing program has been going for many years, and we wish to continue so. There's also a flyer out the front for all of you, and giving you an idea what the Wellbeing evenings will be over this year. The next one being a very important topic of dying with dignity, which will be a Q&A with our Julie McCrossan on May the 17th. This evening we have, I guess, another very important topic, that of Parkinson's disease. While it may affect about 70,000 people in Australia, it's certainly one of the leading causes of difficulty for a person for a number of years and living with that disease. And I'm sure there are some in the audience as well as those who know somebody living with that disease. So, as an important topic, we have some very good people to talk to you about that topic this evening. We have Julie Austin, who's from Parkinsons New South Wales, who will talk about the work that they do. And Wolper Hospital is very proud to support Parkinsons New South Wales in their endeavours locally. We also have Dr. Paul Silberstein, Professor Colleen Canning, and we have some special guests that are involved with Wolper Hospital's work. Geoff Blicblau, Shushann Movsessian and Jennifer Adams. So without further ado, I'll ask you please to turn off your phones or put them on silent so we can hear the speakers, and ask you to show your appreciation and welcome Julie Austin from Parkinsons New South Wales to speak for a few minutes.
Thank you very much. It's lovely to see so many people here. At Parkinsons New South Wales, we run a very comprehensive service, and a service that I'm really proud to be associated with. I've been with Parkinsons New South Wales now for 8 years, so I've seen a lot of changes take place. One of the changes that I'm most proud about is our information line. When I first started, it was run by volunteers. It's now run by registered nurses. I'm one of those registered nurses. I'm a PD nurse, so I've gone on and done extra qualifications. All of our staff are kept up to date with the latest trends in Parkinson's disease and the latest treatments and how best to help the person with Parkinson's disease. We also have a very comprehensive counselling service that you can access through the information line. It is, Shushann's one of our counsellors there, and we have 2 other counsellors, and we have a 4th one coming on in May. We intend to grow the counselling service. We've had a new CEO start in February. She will be growing the counselling service, the information service, our PD neurological nurses in the regional areas. We will be having more nurses in our city areas as well. The other work that we do is we have a comprehensive education program that will be online in the coming months that you'll be able to see and view. We have education for people in support groups. One of my roles that I do is I actually go out to support groups with the support group leader. I'm coming to Wolper in May, and we have what we call open forums. In these open forums, you get to ask the questions that you don't always get to ask when you go to your neurologist. When you go to your neurologist, one of the things the neurologist will say to you, "How's it going today?" Or "How have you been?" What's your common answer and response to that? "It's been great. I'm good. How are you?" You don't always tell the truth. You don't always say all those little things that do happen during your time in between visits. And they're the things that we discuss. We discuss all the difficulties that you may be having. We do discuss your medications, whether you're taking them correctly, whether you're actually taking them at all. Some people do seem to think that, don't really have to take them. So they're the things we discuss on Infoline as well. We also raise money for research and research grants. Now, when you consider that in New South Wales alone, there's over 30,000 people with Parkinson's disease, we only have about 3,500 members of registered with Parkinson's New South Wales. Our aim is to get at least half of the people diagnosed with Parkinson's disease registered. So I implore you, if you're not registered with Parkinson's New South Wales, please consider it. Our fees at the moment are complimentary, so it's not going to cost you anything, and it gives you access to all of our services. And that's really all I need to say. We do all of this work without any government support. And we can't get government support if we don't have a strong membership. So please help us help you.
Thanks, Julie. There is some information leaflets out the front there for you, just to emphasise some of the work that Parkinson New South Wales is doing. So as is usual, we are going to have two specialist guest speakers on this evening, plus our other guests, and once they've, I guess, spoken to us and talked about the topic, then we'll have a chance for you to ask questions. Our first speaker for this evening is Dr. Paul Silberstein. Paul is a Senior Staff Specialist Neurologist at Royal North Shore and a Visiting Medical Officer to the North Shore Private Hospital. He's a graduate of the University of New South Wales, and he undertook extensive studies in the UK for his doctorate of medicine. He maintains a strong interest in the medical and surgical management of Parkinson's disease and other movement disorders, and has a interesting, I guess, talk about deep brain stimulation. So I'd like to introduce Paul to come and talk to us, and then we'll have a listen to very, very good information. Thank you.
Thank you very much for asking me to come and speak. I've been going to Wolper Hospital since I was a very small boy, so it's a great privilege to speak here tonight. Thank you. Can you hear me or not really? No. Close to the microphone, is that better? More? How about that? Okay, thank you. So this is, I've been doing talks on Parkinson's disease for many years now to community groups, but there's definitely two firsts for me tonight. I've definitely never ever done a talk in a movie theatre, so that's definitely a first. And I've also never, still can't hear me? Better? Okay, so look, I've never done a talk on Parkinson's disease in a movie theatre before, and I've never done a talk where my children are in the audience. So I can tell you I'll be on my absolute best behaviour tonight and try and give you the best possible talk I can. Parkinson's disease is a big part of my clinical practice. Probably about 75 to 80% of the work that I do now relates to Parkinson's disease. So I'll tell you a little bit about it. There's been a lot of changes in the last 5 to 10 years in terms of what we understand about Parkinson's disease. And one of the most interesting has actually come from autopsy studies from people who've donated their brains, and then we've gone back and looked at their clinical histories and compared them to the changes that we see in their brains. And one of the really interesting things about Parkinson's disease that we now understand is it's a condition that slowly involves the brain, starts at the bottom of the brain and seems to slowly progress up the brain in terms of its clinical involvement. And the reason that that's really interesting is it's developing these models of what we think about what might cause Parkinson's disease or the way in which the changes progress. And perhaps these are areas that will help us in the future to understand ways of slowing down PD as we better understand these changes through the brain. So Parkinson's disease was always thought of by neurologists as really just a disorder of movement. People with Parkinson's disease have a variable combination of tremor and stiffness and slowness, and sometimes later in their disease course in terms of gait disturbance. But we certainly understand now that there's a lot more to Parkinson's disease than trouble with movement. And we understand that Parkinson's disease affects sleep, it definitely affects mood and anxiety, it can affect bladder and bowel function, and very late in Parkinson's disease it can also affect cognitive performance. And certainly as neurologists, we were a bit late to come to this, to understand that there was a lot more to it than just what we were seeing. So what's the natural history of Parkinson's disease? One of the things that I'm at pains to tell patients when I see people with a new diagnosis of Parkinson's disease is that the course is long, and people do well for long periods of time, sometimes punctuated with periods of more difficulty, but we understand pretty well how Parkinson's progresses now, and that helps us a lot in terms of telling us what interventions may be useful at different times. So typically with Parkinson's disease, people present with symptoms, sometimes easily diagnosed, particularly when people present with tremor, sometimes more difficult to diagnose. For example, a frozen shoulder is a very common first presentation of Parkinson's disease, and often it takes people a year or two to actually be diagnosed. But once people are diagnosed and they start on treatment, usually within 3 to 6 months we can achieve a very substantial improvement in their physical symptoms. And so by substantial I mean people usually improve by of the order of 60 to 80%. And then from that time, usually for a period of some years, people maintain good stability in terms of consistent clinical improvement through the day on a 3 or a 4 times a day medication regime. The difficulty that we know happens later, and usually at a rate of about 10% of people per year, is that people start to develop these motor fluctuations. So what that means is they take a dose of medication, and instead of just the next dose working seamlessly, they find that that dose is wearing off at the end of that dose. And so people start to have these fluctuations where when the medications are working, they feel well, they move well, but when the medications are wearing off, they stiffen up and they slow down. And this problem tends to slowly progress over time. There are a whole variety of different interventions that we can use to try and smooth out that process, and I'll talk with you more about that. But we know this difficulty of motor fluctuations can be progressive as the years go on, and these are what we call these on-off fluctuations, and typically they begin to occur in people 5 or 10 years after diagnosis. Late in the disease, people can develop new symptoms that don't respond as well to medication, and that's where ancillary therapies and the therapist, physiotherapy, occupational therapy, social work can become a really important part of the management of Parkinson's disease. So this is a busy slide, and actually even on a really big screen, it's hard to see all the aspects of it. But this is really just to remind me to talk about the other, what we call non-motor aspects of Parkinson's disease. We know there's a lot of psychiatry in Parkinson's disease, and I'll talk with you more about that. Sleep trouble, bladder and bowel disturbance, trouble with sensation, so sometimes pain and pins and needles can be very prominent symptoms for people. So if we talk a little bit more about the psychiatry, one of the things that we've understood really only well in the last 10 years is that with these fluctuations in people's physical performance, also what sometimes happens is people have fluctuations in their sense of psychic well-being or their psychological state. So when the medications are working, they tend to move well, there's minimal tremor, they walk reasonably well, but also sometimes there's some mood elevation that goes along with that. And that mood elevation, people can be actually quite euphoric from the medication. By contrast, when the medications wear off and people stiffen up and slow down, we used to think that them feeling a bit sad or a bit low was just part of that wearing off, a part of the fact that their physical symptoms weren't really as well controlled. But what we appreciate really now is that actually those psychic fluctuations can be part of people's Parkinson's disease. And when the medications are wearing off, not only do they move not as well, not only may they be stiffer and they're walking more disturbed, but also they feel flat or low or irritable or sad. And we recognise this is an important part of the symptoms of Parkinson's disease that for patients I think is also something that's difficult to articulate because the psychic fluctuations very much go along with the physical fluctuations. And certainly one of the things that we've understood is that actually to treat people well with Parkinson's disease, it's definitely not good enough just to treat physical symptoms. We need to concentrate on psychiatry and other aspects of their condition. So what about the psychiatry of Parkinson's disease? This is the bit that everybody doesn't like talking about. Patients don't like talking about it and doctors don't like talking about it, and we're not so good at accessing it. But it's such a critical part of it, and so often in my patient with Parkinson's disease that I see when things are not going so well, it's because of psychiatry, and unless we treat that well, patients don't get the maximum benefit that they can. So depression is really common. How common is it? About 50% of people with Parkinson's disease will have a major depression at some part of their disease course. What's a major depression? It means feeling flat or low or blue, not enjoying life in general for periods of at least 2 weeks. And this can go on for months and months and months when it's untreated. Anxiety, also a really common problem. About 50% of people have a genuine anxiety disorder as part of their Parkinson's disease. It's not just that they're sad and anxious that they've got Parkinson's disease. We recognise it's part of the biology of the disease. And a lot of my time I spend trying to explain to people that it's like not treating depression and anxiety in Parkinson's disease is like saying, well, I'm going to treat your tremor but not your stiffness. It's kind of just integral to the disease and very important that we treat it. We recognise this dopamine dysregulation syndrome where patients actually take too much medication. So instead of trying to take medication to make them move better, they start taking more and more medication to try and feel better. And in fact, addiction to Parkinson's medication can be a major problem that we sometimes need to deal with. We know that some of the medications, particularly the dopamine agonists, which I'll talk more about, can cause problems with impulse control. You've probably all read about in the newspapers, gambling, excessive spending, hypersexuality. These can be common side effects of Parkinson's medications and ones that people are just not happy to talk about. Late in PD, we can see cognitive disturbance and really hallucinations and psychosis, really, which predominantly in Parkinson's disease relates to hallucinations, are very late features of Parkinson's disease and often symptoms that we can interface quite well with medical therapy. Okay, so what really happens in the course of Parkinson's disease? We've talked about this a little bit already. Patients start on medication. They usually achieve a period of consistent, good control of their physical symptoms and also sometimes with adjunctive therapy, their psychiatric symptoms. And that period lasts for some years. So this is the so-called honeymoon period. I always think that's such a terrible name because nobody really feels like they're on a honeymoon. But really what it refers to is the fact that on a 3 or 4 times a day medication regime, patients have consistent, stable control of their symptoms. With time, everybody starts to develop these fluctuations. At the end of a dose, they feel a bit worse, they take a dose, feel better, and that problem tends to accentuate over time. This is really where most neurologists spend a lot of time working with medications. So we can layer the medications, we can fractionate the medications, and very often, by doing that, we can achieve a nice, consistent, reliable response to medication again. The difficulty is that as time goes on, these fluctuations, they do tend to recur. And sometimes, by again changing the medications, we can achieve this period of relative stability. But ultimately, everybody who has Parkinson's for long enough will get to this period where their medication response just becomes more inconsistent and more unreliable. And so what that means is some doses might not work at all. Sometimes patients might feel good all day. They might have a good, consistent effect all day, and then the next day, for no particularly good reason, the medications just aren't really working. And when people get to this stage, it gets very difficult with tablets to really achieve this nice, consistent control that we've achieved before. And this is really where we start to consider some of the advanced therapies for Parkinson's disease. Some of these have been around a long time. Apomorphine, an injectable form of medication which we give using a pump. And deep brain stimulation, which I'll talk in more detail about, really my clinical interest, now has been around for more than 25 years. The new kid on the block is this treatment, which is called duodopa. One of the problems in Parkinson's disease is that the stomach tends to empty a little bit more irregularly and unpredictably than normal. And so what happens is the medication just sits in the stomach and doesn't get into the intestine from where it's absorbed. And so this medication, what happens is we put a permanent feeding tube in the stomach, which is then extended down into the intestine, and the medication is delivered in a gel form directly into the intestine. And all 3 of these therapies can be very effective in ironing out those fluctuations when they become unpredictable and inconsistent and not really well controlled with tablet therapy. So my main interest is deep brain stimulation. This is an area that I trained in the UK in the early 2000s, and I've been using this therapy in Australia with a colleague of mine, a surgeon, Raymond Cook, since 2004. And this therapy, really what it involves is implanting electrodes, 1 in each side of the brain, and connecting those electrodes down to a stimulating device, which is really just a pacemaker which sits in the chest wall. the electrical current is actually remarkably simple. It's really just a square wave pulse for those of you that are interested in electronics. And that square wave pulse, we think what it does really is to jam some of the abnormal signals that happen in Parkinson's disease. So it's probably not the perfect analogy, but if you've got a 6-cylinder car and 4 of the cylinders are working well and 2 of the cylinders are not working well, unpredictable, unreliable, the car doesn't really run that well. But if you take those 2 cylinders out, the car can run reasonably well on 4 cylinders. And the good news in Parkinson's disease is that the brain, like most of our organ systems, actually has a lot of reserve. So we can do without bits of the brain, we can do without bits of brain function, and other areas of the brain can take over that activity. And probably that's how deep brain stimulation works. We take out some of the bad activity, and then the compensatory mechanisms that exist in the brain take over some of that function. And probably that's how deep brain stimulation works. So this is our experience with DBS. You can see that actually most of our work has actually been in Parkinson's disease, but we do treat a number of other conditions which are refractory or become refractory to tablet therapy over time. And most of our work has been in Parkinson's disease, and most of our work in this area of the brain called the subthalamic nucleus. And the reason that we use that area of the brain is really this target with chronic stimulation can provide a more consistent and reliable benefit than medications can when the medications are no longer doing what they were before. Okay, so what does deep brain stimulation actually do? So this is a rating scale that we use to score how severe our patients are. And actually the rating scale actually goes from 0 to 108. This is some of our own data, probably from about the first 75 patients that we operated on. And so what we do with all our patients is we see them before the surgery, we see them off and on their medication. And the reason we do that is that difference between what they're like at their best on medication and what they're like at their worst off medication is a very good predictor and a very robust predictor of what benefit they're going to get with medical therapy, with surgical therapy, pardon me. So what does this mean? So when a patient has a score of 50, it usually means that they have some difficulty walking, sometimes a prominent tremor, and it certainly means that the medication effect is fluctuating. When they're on their medication, it means they're getting a good symptomatic benefit. It means stiffness improved, slowness improved, walking is improved. And that difference can be very clearly translated to predict the benefit after surgery. And so what we know after surgery is that actually the best people doesn't get any better with surgery. In other words, when people are getting their best medication response, after surgery they don't do better than that. But the big improvement in these patients who are fluctuating significantly through the day is that their worst improves substantially. And in fact, when people ask me, what does surgery really do? It gets people to about 75% of their best medication response, but in a consistent and reliable fashion. Some of our patients, as a complication of their medical therapy, have also developed excessive and involuntary movements that we call dyskinesia, and surgery is very effective at ironing out those dyskinesias. And because the stimulation takes over a lot of the effects of medication, it allows us to make a substantial reduction to people's medication. And one of the really interesting things for me working in this area is that we recognise a lot of symptoms that we think are just Parkinson's disease are actually side effects of medication. And as we start to bring down the medication, sometimes people get a substantial benefit from that alone. So really what the surgery is doing is making things more consistent and reliable when the tablets are not doing that anymore. And it's doing it at the level of about 75% of the best tablet response, but in a fairly consistent and reliable fashion through the day. Okay, so I'm going to try and show you some videos. Thank you for helping with that. So if we just run the video. Okay, so this is a chap who is actually on the day of his surgery. Sorry, can you hear me now? So this is a chap with very severe tremor as part of his Parkinson's disease. In fact, interestingly, people who often have this severe tremor often have less of the other features, the stiffness and slowness. So this is a chap with severe tremor related to his Parkinson's disease, and this is actually on the day of his surgery. And if we run the video, we can just pause that video now. And if we just run the video next to it. So this is a video of him actually on 2 days after his surgery. And and the tremor is completely suppressed. Now, it's always dangerous showing these videos because often actually to get the maximum benefit from deep brain stimulation takes some months, but the tremor suppressive effect can be very impressive and can really come on over days. And so you can see here he is 2 days after his surgery, really with no tremor. If we just go to the next slide. So this is another kind of problem that we see in patients who come to surgery. So this lady, yes, if you run that video. So this lady has excessive and involuntary movements as a complication of her medical treatment. And in fact, her involuntary movements were so severe that she preferred at these times to be sitting on the floor because you couldn't really fall anywhere when you were already sitting on the floor. So here she is before the surgery with a lot of involuntary movements. I always suppress the sound because she's having a very interesting talk with the surgeon about crystals in this video. So if we just play the video afterwards. So this is a video of her now a few days after her surgery. Now the medications are effective here, but you can see that the involuntary movements are very well suppressed. So early after surgery, we often see that there is some fluctuation, but gradually with time, we're generally able to provide very good suppression of tremor, and also very good suppression of these involuntary movements. This is the same fellow, if we just run this video. So this is the fellow that you've seen in the pre-operative video, and this is now about 18 months after the surgery. Sorry, pardon me, if you just run the video. And you can see he's still got really excellent tremor suppression. And one of the really interesting things about deep brain stimulation is that whilst we do see new symptoms emerge later on in the disease course, which I'll talk to you about, the tremor suppression really does appear to be lifelong. And as long as the stimulation is running, the tremor suppression is persistent long term. Okay, so everybody always asks me, well, how long does the benefits of the surgery last? That's all very well. You're showing me these nice videos, very impressive effect early on, but how long do the benefits last? So tremor we've already talked about. The tremor benefit really seems to be a lifelong benefit. The benefit on the rigidity, which is these bars in the white down the bottom, is a fairly persistent benefit either off or on medication in the long term. And this is from a series of patients going out to 9 years. So it's a very long-term benefit on the tremor and the rigidity. What we see in patients after many years from surgeries, we see the emergence of new symptoms that don't respond so well either to stimulation or to medication. So we see, if we see our patients sometimes out at 10 years post-surgery, they'll have excellent tremor control, they'll be comfortable in sitting in a chair, but their speech will be quieter and walking will have become more difficult. And so the way in which patients who've had surgery get into more difficulty later on is by the emergence of new symptoms that in fact were going to come irrespective of whether they had the surgery or not. But this consistent ironing out of clinical benefit, this consistency through the day is something that we see as a very long-term benefit of the surgery. Okay, so this is another patient, if we could just run this video. This is a very long-term follow-up. This lady I've been following now actually for more than 10 years. And this is a video of her before the surgery. You can see she's got very prominent tremor. She's got quite significant slowness of her movement. So the difficulty with movement affects both the upper limbs and the lower limbs. And you can see here that she's got a lot of difficulty getting out of the chair. So these are what we call the axial or the midline symptoms of Parkinson's disease, where there's stiffness and slowness in the axial or truncal muscles as well as in the arms and legs. And this is a video of her now at more than 7 years post-surgery. You can see that her tremor is still very well controlled. It's quite unusual to be on no medication. In fact, we find most patients feel better on a little bit of medication than no medication, mostly I think for their psychological well-being. But you can see that she's still got really excellent control of tremor and also excellent control of her movement. Now, of course, not all of our patients are like this at 7 years, and that medication challenge and the number of years people have had Parkinson's disease predicts really how long and how well people are going to go. But you can see that certainly for some patients there's a very durable, substantial benefit to surgical treatment. Okay, so I guess that's a lot of the positive stuff about surgery. What's the downsides of surgery? So nobody ever wants to have an operation. In fact, interestingly, it usually takes the patient's general neurologist about 2 years of cajoling to get people to come and see me, and then sometimes it's another year or two before my patients have surgery. So nobody likes the idea of surgery. Certainly nobody likes the idea of having holes drilled in their head or wires put in their brain. So the question is really, how dangerous is surgery? And the techniques for surgery have definitely improved even since I've started doing the surgery, but it is a very well-established technique. And probably one of the reasons why surgery has lasted as long as a durable therapy is because the safety of the surgery has definitely improved over the years. So in our series, so we've operated on over 400 patients now with Parkinson's disease. Touch wood, we've had no deaths. We have unfortunately had one patient who had a significant hemorrhage related to their surgery, and that patient definitely worse off for having had the surgery than not having had it. But generally speaking, the operative risk of a disaster is quite low, usually of the order of 1 to 2%. Everybody always worries about whether surgery is going to change who they are. Is it going to change their personality? Is it going to change their thinking or their cognition? There's been a lot of studies of this, and the only real data is that people's verbal fluency is not quite as good. So sometimes people find that just catching the word they want to say or the fluency of their sentences is not quite as sharp as it was before. But interestingly, across many other cognitive domains, we really see no change, and we definitely see no change in memory. Mood is a big issue for us and something that we have to watch very carefully after surgery. We know that a lot of medications make people feel a bit too good, and we know that not enough medications for their Parkinson's make people feel a bit flat and low. And one of the challenges in managing patients in that first 6 months after surgery, as we increase the stimulation to gain that consistency, is that I don't cut the medications back too quickly so people look good but don't feel so good. And that's a balancing act that's just a regular part of my day-to-day practice. Interestingly, we know that there is a suicide risk with surgery. You say, why would there be a suicide risk in a therapy that's very helpful? And this kind of just brings us back to the fact that people with Parkinson's disease who are coming to surgery, there's often a lot of other things that have happened in their life, and there's a lot of mood issues that we have to be careful of. And in fact, we take this so seriously that we insist that all of our patients have a pre-operative psychiatric review to understand their baseline status, so that there's a psychiatrist who knows them, who can help if we need their help, and somebody who's also going to pick up on those people who are high risk. So what about this suicide risk, 1 in 200? It's interesting that it actually turns out that that risk is the same whether you have the surgery or not. So patients who come forward to surgery, when they've compared groups of patients, those who've gone on to have surgery and those who have not, the suicide risk actually is about the same. And probably that tells us a little bit about the severity of people's symptoms when they're coming to surgery, but it also probably tells us a little bit about those people who are actually willing to consider surgery, because sometimes people need to be a bit more adventurous to actually consider to have the surgery in the first place. So this is really just to remind me again about this issue about the fluctuations, and so we see these fluctuations in both people's physical and psychiatric state before the surgery. When they're on, they're jumping for joy. When the medications are wearing off, people feel flat and irritable and low. And we have to be careful that we don't see a distinction between these two, where we achieve this nice consistent physical control, but where people's mood or anxiety is dipping away afterwards. This slide is really just to remind me about the kind of journey that people take with Parkinson's disease, often in coming to surgery. And the longer I look after people with Parkinson's disease, the more I realise that really living with chronic disease, there's a number of acceptance humps that people have to get over. There's definitely an acceptance hump when people are first diagnosed. It's often a time when people have a lot of anxiety. There's an acceptance hump when the medications stop being as consistent, and there's an acceptance hump when you realise that medications just aren't going to quite do the job, and you need to be thinking about one of these other therapies. And I think these are hard hurdles for people, and I think people just need to be supported through them. But there's also acceptance humps that come after surgery, when more difficult symptoms occur many years later. And I guess a big part of my practice is not just doing the fancy stuff, which has all the great technology, but just looking after people as they go through these stages. And I guess I can't really emphasise that enough. And I think Parkinson's New South Wales and other organisations that do a lot of support for patients really help people a lot in these times, because I guess like all things in life, there are good times and bad times, and you've got to be able to get through the bad times to get to the next good time. What about the other problems with surgery? We see occasional lead fractures. We've seen 12 lead fractures in our series. So a lead fracture is when the wire actually breaks. So it doesn't actually break into the brain or break out of the skin, but it breaks within the insulation that goes around the wires. And that's something that needs to be fixed surgically. Unfortunately, we don't have spare parts. We just have to put the new parts in again. And so obviously a lead fracture in the brain lead, which is actually very uncommon, we've only seen 2 of those, requires actually doing the whole operation again. But I think like having an artificial hip or an artificial knee, having a prosthesis put in you, you have to just accept that there is a long-term risk, albeit a low risk, of problems with that prosthesis. Infection, interestingly, infection, you would think that most of the infections would be around the time of the surgery. In fact, some of our infections we've seen many years later, 5 or even more than 5 years after the surgery. And I guess it's like having a knee or a hip again. You know, if you have a knee replacement, you've got about a 1% risk of having an infection in that. If you have a redo knee replacement, it's 2 to 4%. So all prostheses have a risk of infection. And I think if you're going to have the surgery, you just have to accept that that's part of the long-term risk. In the long term, as we've discussed, speech being a bit quieter, and progressive gait disturbance are things that we see happen years after the surgery. Okay, so I'm nearly done. When to consider surgery? This is what everybody always asks. And of course, my experience on looking at it from one side is that patients always have surgery much later than they could really gain a lot of the benefit. And this sort of clinical hunch that we've had for some years has actually now been borne out in this was a very sophisticated study published in the New England Journal, which is kind of the be-all and end-all of medical journals if you want to get something published. And what they did is they took younger patients with Parkinson's disease, actually less than 60, and they offered patients surgery much earlier than we do generally in clinical practice. So as soon as patients had fluctuations or as soon as they had involuntary movements, they were considered eligible for the study. They didn't have to go through multiple trials and medication changes. And what they did is they took 125 patients and they operated on them straight away, and they took 125 patients and they watched them for a couple of years. And what they found was that with every measure, the surgical group did better than the medical group. So these were patients much earlier. If we look at our series, our average duration of Parkinson's when people come to surgery is about 11 years. In this series, they were actually operating on people at an average of 7 years after the onset of their Parkinson's. And interestingly, even operating on patients so early, it was very clear that the surgical group did about 22% better in terms of their physical performance and their quality of life than the patients who just continue with medical therapy. And to me, that sort of says a lot about the troubles that can be associated with medical therapy and the side effects of medical therapy. And I guess it's also just an important reminder that not doing something doesn't mean you have no risk associated with that, because there are risks by not treating. Okay, so to summarise, what are the new things that we know about Parkinson's disease in the last 10 years or so? We've got a very good understanding of the natural history of Parkinson's disease. There have now been a number of studies which have followed patients for 20, 25 years, and that's where we understand this data about the way in which PD progresses and the target points at different stages of the disease. We understand that it's super duper important not just to be treating physical symptoms, but to be treating patients' psychiatric symptoms and their sense of well-being. It's important that we treat sleep disturbance, it's important that we treat blood and bowel disturbance, and it's important that we ask questions about this to maximise on the outcomes for our patients all the way along the course of their Parkinson's disease. We know that we've got lots, in 2017, we've got lots of really good, robust, effective treatments. A lot of my patients are looking around, always looking for something else. And often it's just a question of really trying to fine-tune and finesse the medical treatments that they're on to achieve a substantial benefit. We know that most patients achieve really effective symptomatic control for many years, but we know that there are some more difficult periods that come in between those where sometimes you have to up the ante to the next level of treatment to maintain that consistency of symptomatic benefit. And I guess really the most important message, and the message that I really try and give my patients, I guess, at diagnosis and all the way along, is that people can live extremely well with Parkinson's disease for a really, really long time, more than a decade, and sometimes more than 2 decades. So I have patients who have had Parkinson's disease young, who developed Parkinson's in their 40s, who are living at home with their spouse independently in their 60s and 70s. So you can do really well with Parkinson's disease for a really long time. You've just got to be able to engage with the therapies and also engage not just with the physical symptoms, but also a lot of the non-motor and psychiatric symptoms. What about the future? Everybody's always asking about the future. Where's it all going? So I'll tell you about a few interesting things that are in the pipeline. There's definitely a few symptomatic drugs that may be helpful for things like excessive and involuntary movements. One of the things that the Michael J. Fox Foundation, which has been a very active... Sorry, you lost me again. I'm never quite sure how far I should go back. Symptomatic therapy, so there are new drugs to treat the fluctuations and the dyskinesias that are in the pipeline, probably will be coming out in the next few years. Rebadging new therapies is a big new project. The Michael J. Fox Foundation, which comes out of the US, has been very active in this, trying to use drugs that are already existing in clinical practice and now trying to rebadge them and use them in Parkinson's disease and other conditions. And so the rationale there is from the lab to a new drug takes 25 years, but if you can rebadge old drugs, maybe you can achieve symptomatic benefit much faster. And there's some big trials starting up, and in fact there's some big trials starting up out of the Garvan Institute here in Sydney later this year. I guess for us, everybody's looking for a cure for Parkinson's disease. Many people think that actually before there'll be a cure, there'll be something that will slow Parkinson's disease down. And because Parkinson's disease is such a slowly progressive condition that really develops over many years, if you could halve the rate of progression, most people would die with mild Parkinson's disease, because the average age of onset of Parkinson's disease in Australia is 60. And so if you could live well with Parkinson's disease till you are 80 or 85, that's going to make a big difference. And so there's a lot of interest in trying to find treatments that may actually slow Parkinson's disease down. In terms of what's happening in my world, in the stimulation world, one of the really interesting things that people are looking at now is what we call closed-loop stimulation. So basically at the moment, with the current stimulation models, we just deliver continual stimulation. And that doesn't really vary whether patients are awake or asleep. It doesn't vary with what their medications are doing. It doesn't vary with what their mood is doing. But there's this interest in this idea that, in fact, if we could record from the brain and process that information, that could change the output. So kind of like having smart stimulators, like you have a smartphone. And interestingly, the work that I did, the research that I did in London, some of the algorithms come off that work and have come into this practice. So you just never really know what the things you do in life and where they kind of take you to. We're also looking at new ways of delivering stimulation. So at the moment we use an electrode that just spreads the current in a circumferential way. But there's new electrodes which will be coming out in the next few years which will allow us to shape the way in which we deliver current. And probably the science fiction is these kind of electrodes that have maybe 40 different electrode points and allow us to really shape and tailor the direction of stimulation to really try and maximally control symptoms. And these things, obviously, mere mortals are not going to be able to program this. We're going to need computer algorithms to be able to do this work. Everybody always talks about stem cells, and I think stem cells is a really fascinating thing. I don't know which is going to be the next big change. Certainly I can tell you today that it's possible, and at Royal North Shore where I work, it's possible to take a biopsy of skin cells and in the lab to change those skin cells into neurons, into brain cells, and to change those neurons into neurons that produce dopamine. And so dopamine is the major deficiency in Parkinson's disease. And so there are these amazing cellular technologies that already exist and are useful in the lab. And in fact, there are studies going on now worldwide which are taking some of these lab-grown stem cells and reimplanting them back into the brains of patients with Parkinson's disease to see what happens. We don't know what's going to happen. Everybody always thinks stem cells are going to be the panacea, and it might be. But certainly the technologies and the changes that have happened in this space in the last 10 years are quite extraordinary. And I can tell you from my point of view, it's always hard to kind of keep up with it. I guess it just leaves me just to acknowledge the people that I work with. Certainly this surgical work for Parkinson's disease is very much a team effort. I've worked for many years now with Raymond Cook, the neurosurgeon, and we do the operative work together. We have a psychiatrist, Linton Ma, who works with us regularly. We have a whole lot of other neurologists that we work with that do programming. I'd like to say I can look after everybody, but there are not enough hours in the day. And these are all people who've trained with our unit, who look after patients with deep brain stimulation and look after the programming long term. And for the first year, this year, we actually have a neurologist who's doing specific training on a long-term basis with us in deep brain stimulation. So I think I'm done. Thank you very much for listening.
Thank you, Paul, for all of that. And for those that aren't here this evening and for those who'd like to refresh their memory with all the work that Paul has talked about, it'll be on the Wolper website in about a month, as many of our other previous evening presentations are. Our next guest speaker is Professor Colleen Canning, who is Head of the Discipline of Physiotherapy, Health Sciences, University of Sydney. And she is committed to developing and testing exercise interventions, as we talked about gait disturbance, the issues of your need to be, I guess, physiotherapy, improved in your walking and not falling over. And she's here to help us promote health and wellbeing in people with Parkinson's disease and other neurological disorders. We welcome Colleen. Thank you.
So I'd like to thank the Wolper Hospital for inviting me to speak to you tonight. Improving exercise habits and mobility of people with Parkinson's disease is a real passion of mine, so it's really something I enjoy doing and spreading the word. This is my only slide that's gone a bit corrupted with the technology this evening, but I will talk you through it. I'm taking you back to down here, and the light isn't very good, so I can just see it. Go back to 1980. Okay. I'm not sure. Can I hold the microphone? I'd be happy to. Or will I disturb something else if I do that? Shall we try that? It is a bit of a challenge to talk into the microphone and also to look at the slides because we don't have the computer in front of us. But we'll see how that goes. So this is me back in 1980 over here, young graduate physiotherapist. Absolutely no evidence that exercise had any impact on Parkinson's disease. Now imagine a line that does this. If you can follow the little red marker through 5 studies, randomised controlled trials, 19, 43, right up here, passed off the slide now in 2017. So, and you can see historically it was thought that there was insufficient evidence that exercise was perhaps likely efficacious, clinically useful, but really we're getting an exponential increase. And so there's no doubt now that exercise is beneficial for people with Parkinson's disease, both in terms of its mobility benefits and its quality of life benefits. However, I would like to point out that I'm not suggesting that exercise takes the place of optimal medical and surgical management. So it's always in combination with optimal medical and surgical management. On this slide, I've summarised some of the benefits of exercise. I'm not going to talk about all of them tonight, but the ones up the top that are in bold are the ones that we're reasonably confident about now, that there are now a large number of studies that have shown improvements in mobility, walking, balance, strength, exercise capacity, so how hard you can work, and exercise efficiency, whether you can go for longer when you're working not at your absolute peak, as well as an impact on the motor symptoms of Parkinson's disease that I'll talk a bit more about, and reducing falls. You'll also see that some of the proposed benefits where the evidence isn't so strong but which is emerging also addresses some of those non-motor features that Paul was talking about earlier. So there's a lot of potential here for finding additional benefits into the one, as well as the ones that we're already familiar with. So what am I going to talk about tonight? So why is exercise important? I'm going to focus on reducing motor symptoms of PD because there's some interesting work, relatively new work in that area. Fall prevention, because it used to be thought that we could do nothing about preventing falls. And I'm going to ask the question, does exercise intensity and type matter? Because it's one thing to say exercise is important, but what type, what intensity of exercise? And what about incidental everyday activity that isn't necessarily an exercise program, but it's active walking to the bus station or walking up and down stairs instead of getting the lift? And then I'm going to talk about getting motivated and staying motivated, because that can be really difficult, not just for people with Parkinson's disease, but for everybody. So first of all, motor symptoms of Parkinson's disease. So I'm going to talk about a couple of studies that have measured the motor symptoms of Parkinson's disease. So some of the examples Paul was showing you in his slides. Looking at the amplitude and the speed of movements. This also includes some measurements of gait and balance. But what's important in these studies is that those measurements were taken off medication. So typically the measurements are done on medication, but these studies have measured off medication, and so they give us a little bit of a window into whether there's an impact of exercise, perhaps more directly on the disease process. So the first one was carried out in the United States, and this was a rather long study over 24 months, and people did a range of muscle strengthening exercises at relatively high intensity compared to a control group who did relatively low intensity exercise. Now, the slides I know might be a bit of a challenge, but the take-home message is on the right. So if we look at the first slide, the first graph, we're looking at UPDRS 3 motor symptoms, so motor symptoms. The dark line are the people with Parkinson's disease over the periods of months that the exercise program was conducted, and the dotted line are the dark line are the people who did the resistance exercise, the dotted line are the people who did the low intensity exercise. And of course, a reduction in these UPDRS scores is an indication of less disease severity. So we can see a real impact on motor symptoms even when measured off. We can also see an impact. Here we're looking at muscle strength, elbow flexors of the arm, and of course an increase is what we're looking for. And again, we see that increase in the people who did the high intensity exercise, but we actually see progressive decline in the people who did not do the high intensity exercise. So one of the messages is if you don't exercise, then obviously you will lose some of that capacity that is underlying and present. Interestingly, these were just strengthening exercises. They didn't include exercises that focused on functional activities like standing up and walking. And interestingly, there was no difference between groups, as we can see here, for the effect on physical function. So that probably tells us something about the type of exercise that we need to consider. And while strengthening exercises are important, we probably also need to consider exercises that focus on the particular functional tasks that people need to be able to perform. And in this slide, I've just summarised what I've been talking about. So this was a very high quality trial delivered over a long period of time. It had quite a high level of supervision, which might not be feasible in the real world in the long term. The UPDRS scores were impressive, the reductions in the intervention group compared to the control group. And in the research literature, that reduction would be considered to be a moderate clinically important effect. There is the important point, I'm hitting the wrong button, an important point about specificity of training. So what we saw was an effect on muscle strength and on motor symptoms, but not necessarily on physical function. Okay, so the second study I want to talk about, which also looked at UPDRS scores measured off, is a partnered dance intervention. In this case, it was Tango Dance. So this was carried out again for over a period of 12 months, 2 times a week, and it was fully supervised in a group setting. So this time, the people in the dance group are the people with the dark lines, and the people in the group that didn't do dancing are the lighter lines. The top graph is the UPDRS scores, and you can see that there were improved motor symptoms, that is decreased UPDRS scores in the people who did the dance, but not in the people who continued usual activity without dancing. The next one is a measure of balance. The mini-best test also measured off, and again, an increase in the mini-best test is an improved balance, and we can see a clear difference between the two groups in favour of the people who did the dancing. These are both graphs that relate to walking speed. The first one is walking speed when it is performed as a single task, and the second one is walking speed when the person is doing an additional cognitive task. So it's looking more at the automaticity of walking. And in both cases, there were improvements in walking speed in the people who performed the dancing exercise compared to the people who did not. Finally, in another publication, there was also an improvement in engagement in leisure and social activities. So the improvements that were perceived by the participants or enjoyed by the participants seem to have an impact on their ability to engage and participate in life to a greater extent than they had been able to do previously. And that's when you take out the fact that they've added the participation of the dance classes. Okay, so again, a very high quality trial conducted over 12 months. It was a feasible intervention. There was a fairly high dropout rate in that trial, which just means that we have to be cautious in interpreting the results. The authors argue that the dropout rate was in part because people with Parkinson's are not keen to go off their medications in order to be tested. Those of you who've had that experience usually involves needing to not take your morning dose and then to come in to be tested, and that can be very challenging for people. Again, a substantial impact on motor symptoms measured off, suggesting that there might be some more direct impact on the disease process itself. And finally, it shows specificity of training. So there were positive effects on balance, there were positive effects on gait, because they're clearly two things that are addressed in a dancing program, and there were positive effects on the person's ability to participate in activities. Okay, so now let's talk about falls. Falls are very common in people with Parkinson's disease. Over 60% of people with Parkinson's disease will fall recurrently, so more than once in any year, and 20% will fall 10 or more times in any year. So it is a significant problem, as you would all be aware. Okay, this is a summary of all of the fall risk factors that have been identified in Parkinson's, and there have been more since then. But what I wanted to point out is if you look up the top, age, gender, for example, these are fall risk factors. Increasing age or female gender are fall risk factors that we can't do anything about. As physiotherapists, though, we're interested in the ones that might be able to be targeted with exercise. So before I talk about that, I want to do a little risk assessment with you all just sitting in your seats. So if you have Parkinson's disease, I want you to answer these 3 questions. Have you fallen in the past year? Okay. If you have, you score 6, and if you haven't, you score 0. Have you experienced freezing of gait in the past month? So if you answered if you answered yes, you score 3. If you answered no, 0. Okay. Do you walk slower than people without Parkinson's? So people of roughly the same age, do you have a sense that when you're on, you walk slower than people without Parkinson's disease? If you do, you score a 2. If you don't, you score a 0. So now I need you to add up those 3 scores to get a total score. So if you answered yes to all of those questions, you would have a total score of 11. If you answered no, you'd have a total score of 0. So have you got your total scores? Okay. So now you can determine your risk of falling in the next 6 months. So if you had a total score of 0, you still have some risk of falling, but it's relatively low. If you had a total score of 2 to 6, you have a moderate risk. And if you had a total score of 7 to 11, then you have high risk. So I want you to remember your score or what level of risk you had, because I'm going to give you some implications about seeking treatment that relates to your level of risk. But now I'm going to tell you about the exercise studies that have been conducted to date. Okay, so we're going to look at large-scale randomised controlled trials, so gold standard trials with more than 100 people in each. Since 2011 to currently. So there are 5 trials of exercise interventions. By the way, there are only 2 trials of medical interventions that are specifically aimed to reduce falls, but that's for a different discussion. So 4 trials compared exercise to no intervention or a sham intervention, and 1 trial compared 2 different exercise interventions. So this slide is a bit busy, but in a way, all you need to do is look at the arrows. So of the 4 trials that compared exercise to no intervention, all of them showed a reduction in falls. And several of them, those that were tested for cost effectiveness, also showed that these were cost-effective interventions. Okay, so a little bit about the interventions. You can see that in the first intervention by Goodwin, balance and strength exercises were delivered, 2 risk factors for falls. In the Lee intervention, Tai Chi was delivered, which specifically targets balance, a risk factor for falls. In the Morris study, there were 2 active groups, a group that did strengthening exercises and a group that did movement strategies. And I've got a slide which will show you what movement strategies are, so I'll wait to tell you that in the end. And in the study that we published recently in Neurology, we delivered balance and strengthening exercises, but also cueing strategies for people who have freezing of gait, because freezing of gait is also a very significant risk factor for falls. So you can see they were delivered in a variety of settings, and that the level of supervision varied between the different studies. In our study, we were really trying for something very pragmatic that could be rolled out relatively easily and that could be delivered at relatively low cost. So there's a little bit of a story in our study where you can see there's this 1 arrow going up. So we were able to do a subgroup analysis where we found that whilst there was a really significant benefit for those patients with low severity and a significant reduction in number of falls, for patients with higher severity, it wasn't a statistically significant result, but it was awfully close. And it certainly suggested that there might be an increase in falls with exercise delivered in this very minimally supervised way. And so that has implications for delivering exercise and what mode of exercise and how the service delivery is organised, depending upon how severe your Parkinson's disease is. In the final trial, which was published just recently, this was an international multi-centre trial, there was a comparison of treadmill walking plus virtual reality, I'll show you some pictures in a minute, compared to treadmill walking alone. And they found a significant reduction in falls in the treadmill walking plus virtual reality group compared to the treadmill alone. They did find a reduction in falls in the treadmill alone, I might also add. Okay, so this slide is from that virtual reality study. Geoff Hausdorff from Israel has kindly provided it to me, but up the top it's a little bit distorted, but hopefully you can see there's a person walking on a treadmill. There is a television screen in front. The person has sensors on their feet, and those sensors are monitored and they appear as footprints on the various scenarios that the person watches as they are walking. And in this one you can see that there's a puddle that the person has to step over. The difficulty of those virtual obstacles is able to be increased and decreased appropriately, but also you can see that there are distractors, so there's kids buying ice cream, and also I've done this training, I did it when I was in Belgium, and you can ask the person or you can give the person a route that they have to follow, so that you can tell them, okay, so now you're going to move to a particular place that is several blocks away, and you've got to take the first left, the second right, and then the first left. And so the person's cognitive resources are challenged as well as their physical resources. And that's one of the reasons that they think that this might be a particularly effective type of intervention. The person, you'll also notice, has a harness on them which is suspended above for safety. So one of the interesting things about this sort of intervention is it probably is something that is going to be available in the future, but it's yet to be tested for cost effectiveness, and it also needs to be tested against perhaps some of the other interventions that were shown to be quite effective. Okay, so I thought you might be interested in what a challenging balance exercise looks like, because certainly challenging balance exercises seem to be particularly important in reducing the incidence of falls. So they can be many and varied. They often will involve some stepping, they'll often involve practicing avoiding obstacles, but perhaps at the same time using large movements of the arms. This person finds it harder to step, and so he's practicing stepping to the side but with some hand support, and this person is being challenged cognitively as well as doing a large amplitude movement where he needs to maintain his balance. I would refer you to the exercises that are outlined in the website, which were the exercises that were used in our trial, but also physiotherapyexercises.com. We're now developing a series of Parkinson-specific exercises that can be downloaded. Now, my intention is not necessarily for people with Parkinson's to go and find their own exercises, because I think it can be very challenging to get the level correct. If it's not challenging enough, it's probably not being particularly useful. If it's too challenging, then it can increase your risk of falling while performing the exercises. So I would advise taking advice on which ones are most appropriate for you. But if there are health professionals in the audience, I'd really advise you to take a look at physiotherapyexercises.com. The Parkinson's ones aren't quite there yet because we're still waiting for them to be uploaded at the back end, but there should be close to 100 Parkinson's exercises on that website in the next month. Progressive resistance or strengthening exercises are important. You can, of course, do these with a range of machines that are available at a range of gymnasiums, but you can also use body weight resisted exercise. So these people on the left are wearing weighted vests, so you can put metal weights into the pockets of the vests and progressively increase the resistance, which is important. And then they're practicing exercises such as stepping up and stepping down, and they can be practicing exercises such as heel raises or sit to stand, all of which have a functional benefit as well as a strengthening benefit. We mentioned movement strategies. So movement strategies were described probably first by Meg Morris in Melbourne, but really it's the use of cues or attention to focus on key movement components. So it might relate to breaking the task of sit to stand into particular steps where the person concentrates on each step. On the right, we can see a person using visual cues to walk in a wide arc rather than to twist and turn, which for people with freezing of gait in particular severely increases risk of falls. So there's a range of movement strategies that are available that could assist and that were shown to be effective in the Morris trial. Okay, so thinking back to your number, whether you were at low risk of falls or medium risk of falls or high risk of falls, if you're at low and moderate risk of falls, then I think the evidence fairly clearly suggests that group or minimally supervised exercise, including challenging balance exercises, is important. And certainly the evidence suggests that you should be starting this exercise as soon as possible. And these, in fact, are the same exercises that you would be doing to increase your mobility. So the old idea that you wait till you've got motor problems to start exercising in Parkinson's disease is just that. It's an old idea and it's not actually correct. What we really should be doing is being proactive. There is actually some evidence that people who exercise over a long period of time are less at risk of developing Parkinson's disease in the first place. But of course, that's just one factor. If you have a history of multiple falls, injurious falls, or falls associated with dizziness or fainting, regardless of what number you've got, you should treat those falls as high risk. So for high risk of falls, I would recommend an assessment, particularly a medical review, to make sure that medication management is optimal and multidisciplinary management is often required. A more extensive assessment from a physiotherapy point of view that looks at, sorry, I've put in the acronym, freezing of gait, various forms of balance, muscle strength, cognition, fear of falling and impulsiveness, which not surprisingly has been shown to be a risk factor for falls recently. Just checking the time. I'm not sure what time I started. Can you give me a bit of an indication of how much longer I've got? A couple more minutes. Okay. All right. So in terms of intervention for people at high risk of falls, higher levels of supervision of exercise would probably be appropriate. There's a real need to consider avoidance or modification of high-risk activities and environmental modifications in the home. All of the things that you might consider for anyone at risk of falls, but things like the use of night lights, looking at clutter, looking at loose rugs and things that can be tripped over. There's a whole range of environmental modifications that an occupational therapist or physiotherapist would consider with you. Okay, I'm going to do the rest of this really fast, but this will go on the website, so you can look at it there. So the question is, does intensity of exercise matter? And to do it really fast, I'm going to flip over all of that detail, and I'm just going to go to the end, which shows that specificity of exercise matters. So in this study, people who did the treadmill walking exercise at either low or high intensity improved their exercise capacity about the same amount, but the people who did the strengthening exercises didn't improve. The people who did strengthening exercises improved on the strength variable, but not on the exercise capacity variable. Interestingly, there wasn't any difference between groups in the walking capacity. So the take-home message is that intensity probably does matter, and I'll give you the take-home message just when I get to the next slide. Don't worry about the details there. The take-home message is at the bottom. Okay, so certainly if you can do high intensity exercise, then you'll get your exercise done a bit faster because you can reduce the duration of exercise, so the amount of time that you do the high intensity exercise. However, if you do lower intensity exercise for a longer period of time, then there may not be a lot of difference in terms of the exercise effects. So this is actually quite important for people who don't feel comfortable exercising at the highest level of intensity or who need to work up towards it. Does type of exercise matter? There's lots of options around now, and that's fantastic because that gives you choice. What does the evidence tell us? There's no strong evidence for one exercise type over another, and I would recommend that the type of exercise targets the specific mobility problems and motor impairments of the individual. So we've made the point about exercise intensity. They're the things to consider for exercise type, and individual preference and whether the person's actually going to do the exercise might actually turn out to be the most critical factor. We've got a study that we're looking at this point in time where we're going to try and find that out. Some guidelines and things to think about if you're going to start exercise. I'll let you read them rather than going through them word by word. Physical activity. Okay. This is the quick tour because I'm mindful that it's late. People with Parkinson's disease, even at diagnosis, are less physically active than other people. These are some of the reasons why. They don't expect that exercise will have an impact. Well, I hope I've changed your view on that tonight. They don't feel as though they've got time, or they don't prioritise the time, and they're fearful of falling, which is a reasonable fear. But if they become more confident in your abilities, then there's less need to be fearful. There are also some of these things that need to be addressed. And so we are very mindful as physiotherapists about the challenges in getting started on exercise, and certainly I would encourage you consulting a physio for that reason. This is my friend Anthea. I wanted to get her engaged in exercise. She doesn't have Parkinson's disease. She agreed to me showing this photo. We both bought ourselves Fitbits so that we had some goals that could be set about walking. This is some of the display you get from a Fitbit. There are lots of other, this is a different form of Fitbit. It's not the only form of monitor of exercise, but there's lots of them on the market now. Getting feedback from the exercise machines that you're using is another way. There are lots of apps. Most of them have not been tested in any way, so again I would seek advice from a health professional in terms of which app you might choose to use and whether it might be appropriate for you, but there's certainly lots of scope. There's the Active and Healthy website, which is a New South Wales health initiative. If you're someone with early disease and looking for an exercise group that's close to home, you can put in your suburb and you can search for exercise opportunities. That includes for people with Parkinson's disease, but also people without Parkinson's disease. There's a bit of extra information about Parkinson's disease on that website. Take-home messages. I haven't talked about sitting, but the opposite of exercise is sitting. We've all been sitting a lot tonight, so I hope you enjoy your walk when you stand and walk out of here. But think about sitting a little less. Try and do a little bit more exercise or physical activity each day. I think if you can find an exercise buddy or an exercise environment that works for you, that definitely helps. And For people particularly with more severe disease, it's necessary to consult a physio. I would actually recommend you consult them early on. Here are some ways of finding out about exercise. Here are some great programs here at the Wolper Hospital. And as was pointed out earlier, the Parkinsons New South Wales info line is a wealth of information. We know a lot about exercise, but we still know that lots of people don't do exercise. We're trying to find out why. So we want to understand what drives people to exercise and what sort of exercise they perform, how much they're prepared to pay, what effect you'd need to get to start an exercise program. So I've got a survey that I would like people to consider completing. It can be done online or it can be done in paper format. I've got 20 paper copies, so if people would like to take a paper copy with them this evening or a flyer to show them how to go online, I'll see you out the back when the session is over. There's another study there too, which you might be interested in getting further information on, and that'll be up on the website, and I'll just leave that there. If anyone wants to quickly write it down, you can ring me or email me about either study. Sorry? I have given it to Parkinsons New South Wales. Getting it on the website has been more of a challenge, but I'm hoping that it will be solved in the very near future. Yeah, no, I've had a good discussion with Joanne, so it's all fine. Thank you.
Thank you very much. Well, we've been given a lot of information and I'm sure a few have questions, but before we do that, we would like to say that Wolper has been in the community for well over 50 years, and there are many in the audience who remember it as being a small surgical and very well-run medical unit. Over time, we've developed and created one of the preeminent rehab programs in New South Wales, if not in Sydney. And with that, I'm going to introduce Geoff Blicblau, who is the Allied Health Manager and head of our rehab day program at Wolper Hospital, and we're going to talk about Move Well. There you go, Geoff.
Thank you, Alan. If anyone can't hear me, let me know. It's a bit troublesome with a microphone sometimes. I'm just going to spend a few minutes talking about the options we have at Wolper Hospital. And the talk that Professor Canning had before was actually a perfect preamble, because she went through a lot of the details about the issues that are faced by people with Parkinson's disease and also the treatment options for them. So one of the things that Professor Canning mentioned about was the importance of physiotherapy and the really importance of early stage intervention. So what we do at Wolper is we have two main options. One of the options, and I see a lot of familiar faces tonight, have actually been through the program. We have a formalised rehab program, which is medically supervised, run through a team of physiotherapists, occupational therapists, nurses and doctors. And the idea is that we would assess you comprehensively and would find out what the issue that you face. And that might be something to do with falling over, it might be balance issues, it might be transfer issues, or it might be simple activities like eating or showering or dressing. And we'll then develop a program that's done generally twice a week for a month or two, and it's quite an intense program. It's generally 3 hours at a time, and it involves intervention by physiotherapist, occupational therapist and hydrotherapy. So traditionally we would do exercises that would be tailored to your needs, so we'd individualise the program, and that would involve, like we just spoke about with Professor Canning, exercises to do with balance, with falls, and a lot of the exercises we do will have you to do at Takehome as well. And the idea is that we would practice with you, we'd supervise with you, but then going home would reinforce those efforts, and that would get you what's called transitional. So you would find the next day and the next week and the next month that the benefits would be there. The other things we do is we do hydrotherapy programs, and there's been more evidence recently that shows us that interventions for Parkinson's disease are proving beneficial in the water. The water is heated, so it's quite comfortable, and there's buoyancy as well, so often people find it easy to exercise. And it's simply the same exercises. Often it's the same balance and it's the same work on transfers, but in it's a very motivating and very warm environment. So often we find that patients are actually much easier able to do the exercises. So that's our formalised approach, which is under the care of a doctor, which is generally referred by a doctor, and we'd assess you. The other approach we have is more of what's called a maintenance program. That's what you can see on the brochure here. So we started this about 12 months ago, and the idea is that we're trying to motivate or encourage people to lead an active and healthy lifestyle. So we run a range of classes, both on the land and in the water, that are aimed at getting people stronger, improving their balance, reducing their falls, and also aimed at people with Parkinson's disease. So the classes we have are a combination, and again, leading on to what Professor Canning said, they're a combination of things like strength training, of balance exercises, and what we call the LSVT big program, which is the big amplitude movements. And something that Jenny will talk about in a little bit about LSVT, we're seeing real benefits with patients who do these programs in both early stage and late stage Parkinson's disease. And I think Jenny will speak about it a little bit in a few minutes, but we are looking really soon to actually set up a formalised rehab program that runs through this LSVT program that will predominantly be by the focus of physiotherapy and speech therapy with Parkinson's disease. So myself and Emma Ogate, who's just in the second row over there, who runs the classes, will be hanging around for a little bit after the actual program. So if you've got any questions or any queries, please let us know. You've also got on your chairs a little handout with information about both the formalised approach of day rehab as well as the Move Well program as well. So please have a read, and any questions we'll be around to answer them as well.
Okay, one more very good member of our team is Jennifer Adams, and she's a consultant speech therapist, and she's going to have a brief talk to us about those issues. Thank you.
Do you think you could step that way?
Yeah, sure. Will you be closer then?
Yep, I will do. Okay, so hello everybody. Thanks very much to the team at Wolper for inviting me to speak this evening. I'm certainly delighted to do so and to speak to you about my association with Wolper Hospital and with Parkinsons New South Wales. So I've been a contractor at Wolper as an inpatient speech pathologist and provided dysphagia education services since July of last year. I've provided multiple in-service presentations to catering and nursing staff, but more recently I've been speaking with Geoff and Dr. Morant about coordinating speech pathology services for his day rehab team. Of particular interest to the Parkinson's community is the speech pathology service LSVT Loud, and hopefully this will be available at Wolper in the near future. So how many people actually know what the LSVT Loud program is? Thank you, a few hands. Oh, quite a few. Excellent. So it's basically, I'll give you a background. It's the Lee Silverman Voice Treatment Program. It was developed in 1987 and has now been implemented for close to 30 years. LSVT has proven to be an effective program for voice and speech conditions associated with Parkinson's disease. Treatment results have been documented to last 2 years post-treatment, and research shows that LSVT also improves common problems like poor articulation and diminished facial expressions and impairment to your swallow. So I'll run through quickly what the LSVT program looks like. Basically, therapy is done over 16 sessions over a single month. There's 4 individual 60-minute sessions per week, and that's face-to-face with your clinician. In addition to that, you have homework. So you'll have 1 hour of homework in addition to your 1 hour with your clinician, and you'll also have 2 hours of homework on the days that you do not see your clinician. So it is quite intensive. But this intensive style of the program is critical to achieve the results that you want. The strengthening of the muscles of voice and speech production, making changes to the nervous system and acquiring those new skills. The therapy also incorporates sensory awareness training, which helps people to recognise their voice because your voice becomes quite soft, and accept basically that the new louder voice is within normal limits. So basically at the end of the 4 weeks, a final session collects data, updated measures to quantify the changes made during the 4-week program. The flyer that's out the front actually goes through all of the program, so you can reread through it, and it also has my contact details on there if you wanted to contact me at any time, and I'm happy to answer any questions. So my other connection to Wolper is my wonderful, charismatic, entertaining and nurturing support group, of which I've seen many members tonight, so thank you very much for coming out. And I've been running that since March last year. And the reason I remember that I started in March last year very clearly is that was the first support group where we met at Bondi Junction, whereas I'm not quite sure if you remember the Mill Hill on Spring Street. I actually had to have my partner come with my newborn baby, Henry, as I had to feed him just before the session and then just after the meeting, and he turned 1 last week. So that's how I know that I've been with Parkinson's New South Wales for a year. So following that first meeting, I was very fortunate to be introduced to the lovely CEO of Wolper, John Tucker, who's up the back there, through Mel Browning, and she is the coordinator of the support groups at Parkinson's New South Wales. John was very supportive of our group's needs, so to provide us a safe space where we could meet each week. Wolper has redefined our support group as the perfect spot to meet in a beautiful sun-filled room overlooking the leafy streets of Wallara, where we enjoy a tea or coffee and cake. Or if you prefer a healthier option, there's always a fruit and vegetable platter where we meet with our newly formed friends. So I believe that our group has the perfect balance of information, support and friendship. We welcome new members each month, and each month we try to schedule something different. So a few things that we did last year. To wrap up the year, we celebrated Christmas with a Kris Kringle lunch at Centennial Park. We saw the new year in with a fundraising planning brainstorming session for the upcoming World Parkinson's Day in April. We have so many incredible guest speakers. Ben, the pharmacist at Wolper, Tabitha McIntosh, who is a naturopath and nutritionalist, Zara Duffy from Dance for Parkinson's, and that's just to name a few. And we've really had some great outstanding speakers. So this is basically a space where you can come and just listen, or to speak about your experiences, your shared life stories, or to ask questions. All judgments left at the door. Friends and family are always welcome, and I think about 1/3 of our group are carers and family members, and they contribute so much to the closeness of our group. So if anyone has any questions in regards to the speech pathology service that are coming up in Wolper, or just speech in general, or questions about the wonderful support group that we do run, please feel free to grab me afterwards. I'll stand out the back for a short time. Or contact me from the details from the flyer out there. Thanks again.
Oh, bit of advertising. Okay, we're going to ask the 2 guest speakers to come and sit down over here, please, and we'll give a chance for people to ask a few questions. It's been a very thoughtful and informative evening. I know we've overwhelmed you with a lot of information, so I'm sure there's going to be a few questions. Michelle's up the back there with a microphone. If somebody would like to put up their hand over there, yes, please.
There's someone there.
Do you want?
Thank you for a very informative evening. I enjoyed that very much. I just have a query regarding motivation and exercise. It seems to be very difficult for both Parkinson's patients and just a regular, normal, non-Parkinson's person to be motivated to carry on with the exercise daily. What advice do you have?
Yeah, it's a very good question. There's no simple solution, but I think and you're correct, there are many people, regardless of whether they have Parkinson's or not, who find it hard to be motivated to exercise. However, we know people with Parkinson's, at least some, will find it doubly difficult, not just because of the motor problems that people with Parkinson's have, but because of some lack of motivation anyway as a result of the disease. So for many people, one of the solutions is to join an exercise group, whether that be, and it might depend upon where people are in their disease course, whether that be one that is specific for people with Parkinson's or not, but then you get the companionship of the people in the group with you. Often exercise groups have an opportunity for some social event that sits around the exercise, so the cup of tea afterwards or whatever. Other people prefer to find a buddy who will support them with their exercise. Many of us will manage better if our physiotherapist gives us a defined exercise plan that we contract together, and gives us some support. So these days, the physiotherapy exercises that I was showing you on the slides, that website also comes with an app where the exercises can be sent to you, to your mobile phone, and where you can tick off when you have done them, and that information goes back to the physio. Now, there are a number of apps that do this, but people tend to be more adherent to exercise if they know that the physiotherapist, the next time they see you, are going to ask, well, how did you go with your exercise, rather than just giving an exercise program which then kind of gets lost on the kitchen table or somewhere else. So there are a range of physical activity monitors which we think might also assist with exercise, but really one of the primary things is finding something that is suitable for your impairments, both motor and non-motor impairments, but that you get some enjoyment from. So I know that there's a group called the Punching Parkos that now is up in Chatswood, I think it is. Now, you know, some people find that that works really well for them. Some people find dancing for Parkinson's disease. Some people prefer to do their own exercise. But unless you've got support, and I think, how many people do you know, or I know, who don't have Parkinson's disease and who don't exercise unless they go 3 times a week with their personal trainer? And of course, these are people who can afford to and choose to pay a personal trainer for that service. So it's not an easy one to beat, but I think if you can find some level of support at a cost that you're able and willing to pay, that makes a big difference. Does that help?
Yeah, there's Burgess Centre has a Parkinson Dance program, and that's and we've got a flyer out off the top there for you. So there's a community services out there for us. Michelle is a person up the back there.
Thank you. I'd like to ask the doctor, what is the relationship between Parkinson tremor and essential tremor? Because I don't seem to have.
Yeah, so both conditions are common. We definitely see some people who've had essential tremor for many years, who in later life will develop Parkinson's disease. We don't think that there's a link between the two. So I think essential tremor is much more common than Parkinson's disease. And I've definitely seen a number of people, you know, over the years who will ultimately develop both. But the two tremors, it's probably just it's a coincidence rather than any causal relationship between the two.
So another question down the front here. Yep.
What's going on with the essential tremor? Okay. It's a continuation about the essential tremor. I was told that it also comes from the brain. So that's the second question now. What exactly do you do when you say you operate?
Sorry, for...
What is involved in the brain operation?
Oh, so we use deep brain stimulation both for Parkinson's disease and for essential tremor. The operations are very similar operations. We tend to use different areas of the brain. because we know from studies and from experience that certain targets in the brain are more effective for some symptoms than for others. The operation itself basically involves implanting wires into the brain, usually about 7 to 8 centimetres into the brain, depending on the target structure that we use, and then connecting that wire up underneath the skin to a pacemaker device. So the operation, it's quite a long operation. It takes 6 or 7 hours altogether. Part of the operation is done with people partially awake. So people generally find that as a fairly terrifying concept. The anaesthetists are pretty good at keeping people lightly sedated and offering good pain relief through the surgery. So, in fact, many people don't really remember too much about the operation, although I know they were definitely awake because I examined them during the operation. Putting the wires in, it relies very much on technology now. So we have fairly sophisticated computer programs that allow us to map where we're putting the electrodes and also to map how we're getting there. And doing the operation is a bit like landing a plane in the dark. You can't see out the window, but you've got a lot of instruments that are telling you where you're going. And one of those instruments is how people respond. So we do stimulation during the operation, and that's one of the ways that we confirm that we're where we want to be. So I hope that answers your question.
Michelle at the back here.
Dr. Paul, what is the age of the oldest person who's had the deep brain stimulation? Is age a restriction if you're over 80?
So I'm trying to find the person who's asking the question. It's like having a voice from above. For Parkinson's disease, the oldest person that we've operated on is 79. There are cases in the literature up to 95. There was definitely this idea in 10 years ago or so that there was kind of this age cutoff of being 70, that if you're older than 70, you were too old to have surgery. I think it's definitely true to say that older people in general tend to get not quite the same level of benefit as younger people do, but I think that's probably true of all therapies and all operations. In our experience, about 20% of our patients that we've operated on have been over 70. So we definitely don't see age per se as a cutoff. People's biological age, so what their general health is like, and also their duration of their Parkinson's disease can sometimes be important considerations. But we sort of live in a very, definitely in the world that age, the number specifically is not important.
Okay, thank you. One last question here because we've had a long night.
Doctor, do you have any information on corticobasal syndrome, please?
Corticobasal syndrome.
Yeah, so
Parkinson, but with advance.
Yeah, so corticobasal syndrome, there are some conditions related to Parkinson's disease. Corticobasal syndrome is one of them, and those syndromes like corticobasal have some of the features of Parkinson's disease, so for example stiffness and slowness. Corticobasal syndrome specifically sometimes has some cognitive difficulties that go with it, and some difficulties with the processing and planning of movements. And corticobasal tends to progress a little bit more quickly than Parkinson's disease does. So in terms of the treatments for it, sometimes some of the medical treatments or the medicines that we use for Parkinson's disease are not particularly effective, but sometimes a lot of the supportive therapies can be very helpful. And certainly treating some of the cognitive difficulties and a lot of the social supports can be extremely helpful for people with corticobasal. But often it's true that the tablet therapies that we use for Parkinson's disease are not always that effective in corticobasal.
Unfortunately, tonight we've had it's been a bit long. Okay, one more last question here. Sorry, we have to wait for a microphone, please. Just in the middle.
I have a question. With the procedure you perform, that means that the medication is actually reduced, right? But which means that with the reduction of medication, the symptoms are suppressed, but the secondary symptoms, the additional symptoms, you can't prevent them from appearing. So does the reduction in medication affects the appearance of secondary symptoms, and if not, then how that affects the procedure you perform, how it affects the period between the you've done the procedure and the effects or the secondary symptoms.
So by secondary symptoms, you're referring to symptoms of Parkinson's disease that come out over later years?
Yes, correct.
Yeah.
Like psychosis and deep depressions and that sort of stuff.
Yeah.
Hallucinations and...
Yeah. So I guess there's probably two answers to that question. I mean, what the surgery is about is achieving good consistency of control of Parkinson's symptoms for a significant period longer than you're able to do that with tablet therapy. And so equally, as with tablets, we don't think that surgery actually affects the course of Parkinson's disease. It doesn't really affect the underlying biology or the progression, but from a symptomatic point of view, it allows a much longer period of control than you can achieve with just tablets alone. The symptoms of your Parkinson's disease that you're talking about, cognitive difficulties, sometimes psychotic features, these are very late symptoms of Parkinson's disease, and they definitely happen in our patients who've had surgery, and they happen in patients who have not. One of the advantages that we see in some of our long-term patients is that because the medication dose is relatively low, some of these symptoms, like hallucinations, tend to be less of a prevalent problem. Because when patients with Parkinson's disease do develop cognitive difficulties after 20 or more years, the higher the dose of medication, the more likely they're going to experience symptoms like hallucinations and psychosis. And by having the medication lower, that can be a helpful thing. But surgery is definitely not a cure for Parkinson's disease, but it can be a very effective and long-term treatment for some people.
Okay, thank you very much. Do you want to say something, everybody? So thank you to the audience for your participation, for coming along this evening. Just a reminder that if we don't know you, then we'd like to get you on our mailing list, and we have, please make sure that you register. The next evening we have is on May the 17th, Dying with Dignity, which will talk about some of the palliative care services we provide. And I just want to say thank you to our speakers again, and we'll see you next time. Thank you.